Good evening, everyone. So, welcome back again. And again, I would like to thank all the participants who have been consistently being part of the Neo Web series, what we are doing, e-masterclass from NNF Karnataka State Center. So, today, two common topics and two less and confused at times. One is the skin and orthopedic issues. So we are going to talk on neonatal dermatology and neonatal orthopedic, the common what we observe, the normal physiology and what we need to look at and how to counsel the parents. So we have Dr. Prasanna Muniyappa and we have Dr. Ravi Kiran. So I request Kishore sir, our Vice President of NNF Karnataka State Chapter, to introduce the speaker and start the presentation session. Over to you, Kishore sir.
Welcome everyone. Good evening. And we have a fantastic speaker, Dr. Prasanna Muniyappa, who has done MD and DNB from Bangalore, and he hails from Bangalore. He spent several years in the UK, worked as a consultant. He's one of the silent worker, and he has been doing neonatology for more than 2 decades. And we will be very happy to listen to his expert opinion about the neonatal skin care. Over to you, Prasanna.
Thank you, Kishore. First of all, good evening, friends. My topic is neonatal skin care. So first, let's see what is the aim of my topic: to maintain skin integrity and minimize the heat loss, and understand the key differences between preterm and term babies, so that we can educate our NICU doctors and nurses to appropriately assess and manage the neonatal skin in the NICU as per the current evidence. My overview of today's talk: first I will let you know the anatomical differences. Then we will see what are the functions of the skin, and I will let you know common neonatal skin lesions, how to diagnose and manage, and we'll see few assessment tools which we commonly use in the NICU, and we'll go through clinical practice guidelines and routine neonatal skin care. I'm sure in most of the units there are various skincare practices. Let us have some consensus. First, anatomy of the skin. As you know, skin has got 3 layers. Topmost is the epidermis and dermis and the subcutaneous tissue. And epidermis has 5 layers. You can see topmost is the stratum corneum. Just beneath that we have stratum lucidum and the stratum granulosum, followed by stratum spinosum. And lowermost layer of the epidermis is the basal layer that has got living cells. And these are the hair follicles. These are the melanocytes. And we have dermis, which contains neurovascular bundles, sweat glands, elastin and collagen fibers, and subcutaneous tissue that contains fat. Let's see what are the differences between 25-weeker preterm baby and a full-term 40-weeker term baby. As you can see here, stratum corneum is very thin. It's only 5 micrometer. But here, this is a term baby. The stratum corneum is thick, almost double the size. And even if you see carefully, the epidermis is also thin in 25 weeks. But here, in term baby, it is thick, almost double the size. And if you see carefully the dermis, here it is less densely populated, all these collagen fibers and neurovascular bundles. But in the term baby, we see more dense collagen fibers and also elastin fibers. If you just concentrate on the stratum corneum, which is 30% thinner in the term skin when compared to adult, but preterm babies have very thin skin, that is only 40 to 60% thinner. And term baby will have around 10 to 20 layers in the stratum cornea. But in the preterm babies less than 30 weeks, they have only 2 to 3 layers. When it comes to 24 week, they almost they don't have any stratum cornea. You can just imagine how thin is the skin. Let's see the barrier function. So full barrier function takes at least 2 to 4 weeks time in most infants. It is almost 8 to 9 weeks in a very low birth weight babies. And the maturation rate. In the intrauterine life, maturation rate is slow. It becomes accelerated when baby is in the extrauterine life. For 23 to 25 weeks, it takes almost 8 to 10 weeks time to mature. Less than 27 weeks, slightly slower than this. And what we saw commonly see in our practice, 27-40 weeks, usually takes around 2 weeks time to mature. And functional skin maturity can take even weeks to months. As you all know, skin integrity impacts on the neonatal mortality and morbidity. So our main intention is to maintain the skin integrity. Let's see the pH. Term baby's pH is around 6.3 at birth. It falls down to 4.95 within 4 days. That helps in formation of acid mantle, which is very important in the barrier function. Coming to preterm skin, it is more than 6 at birth, which falls to 5.5 over first week. Almost it takes 1 month time to reach around 5. In the diapered area, it is usually around 4.7. The adult skin pH is around 4.7. What are the risks? Why we are so much worried about skin? If a skin barrier is not appropriate, that will attract infections and skin irritation and increased water loss and increased absorption of toxins and even epidermal skin stripping, especially when you remove the adhesive tape. And what are the functions? In my opinion, skin is one of the overlooked organ. If you see the functions, it does so many things. You see, it gives a barrier protection against irritants, bacteria, allergens, and toxins. Even it protects the internal organs. It helps in tactile sensory input. It regulates insensible water loss. It secretes electrolytes and water and stores fat, which also helps a major role in the thermoregulation. Even it helps in antigen presenting, we have antigen presenting cells in the skin. There are so many functions. So I request everyone to take it very seriously. In your day-to-day practice, you assess the skin condition. So one of the things we do in the NICU is the giving humidity. Which babies need humidity? Any baby who is less than 32 weeks, or if birth weight is less than 1200 grams, we should give the humidity. What is the benefit? It will help in the decreasing the transepidermal water loss. It maintains skin integrity. It decreases the fluid requirement and minimize the electrolyte imbalance. Usually we start around 80% in the first week and we reduce to 50 to 60% in the second week. Until 30 to 32 weeks we can. And most of the time only 2 weeks of humidity is enough. Because as I told you, the skin maturation is faster when baby is in the extrauterine period. Now I am going to touch upon the common skin lesions we see in the clinical practice. For that we need to understand what are the types of skin lesions. There are mainly 3 types. One is a primary lesion, secondary lesion, and a special skin lesions. This is very important. We have to use the correct terms for describing the skin lesion. It is not easy. Now let us go through one by one. These are the primary skin lesions I am going to talk through. Macule, papule, plate, nodule, vesicle, bulla, pustule, abscess, wheal, and cyst. what exactly it is. So let's see what is macule. Macule is nothing but it's a flat circumscribed lesion showing change in color without a change in consistency. It is basically not palpable. The size is usually 0.5 to 1 centimeter in size. Color may be brown, blue, red, hypo or hyperpigmented. And let's see what is papule. These are the papules. It is a small solid lesion less than 0.5 centimeter in diameter, which is raised above the surface and it is palpable. Next we have plaque, that is indurated area. It is usually more than 0.5 centimeter, which may be raised or depressed from the skin surface. These are the nodules. Nodule is usually large, 0.5 to 5 centimeter, which is firm, raised above the surface. And these are the vesicles. You can see here. That is a small fluid-filled lesion, usually less than 0.5 centimeter, which is raised above the skin. Fluid is often visible and lesions are transparent. Next we have pustule. It is a vesicle filled with the pus, inflammatory exudate rich in leukocytes. Sometimes it may be sterile or it may contain bacteria. These are the bulla, fluid-filled raised lesion. Usually it is more than 0.5 centimeter in diameter. Often it is transparent. Now let's see what are the secondary lesions. Secondary skin lesions, they are not the one to begin with. Later it becomes like this. First it will be primary lesion. Later it becomes secondary lesion because of the scratching or because of the infection. So better to recognize these lesions. So these are the scaling. You can see all the scale. For example, seborrheic dermatitis. This is the crust and these are the fissures. And you can see the skin erosion here. And this is the ulcer and the lichenification, which we commonly see in atopic dermatitis. Let's see some transient papular and pustular lesions. There are 5, but mainly I will be talking about milia, miliaria, and erythema toxica and neonatal. So this is milia. This is nothing but retention of keratin and a sebaceous material, which is mainly seen around the nose, which usually fades away in the first couple of weeks. Then we have milia. This is related to sweat gland. Depending on the level of the obstruction, we have miliaria crystallina, rubra, or profunda. Profunda is very rarely seen. These are the two commonly we see in the neonatal practice. Rubra is also called eat rash or prickly heat. Only the obstruction level is at the different. This is the miliaria crystallina. You can see all these crystal-like lesions here, papules. And this is rubra, which is red and erythematous also. This is heat rash. This is more common in humid conditions, summer or when they apply very tight clothes. Let's see erythema toxicum, which we commonly see. Only name is very scary, but the lesions is benign, and usually it is seen in almost 20% of neonates in the first 72 hours, which is more common if a baby's weight is higher and a greater gestational age. Exact reason we don't know, but one hypothesis is that it is a innate acute immune response to the penetration of skin colonizing flora into the hair follicle, which usually your main striking feature is the erythema, this redness, and you will see a few papules and pustules also. So most important is erythema should be there. It may be present sometimes at birth. Most of the time it spares palm and soles, and usually it resolves within a week. Then we have a neonatal cephalic pustulosis. People most of the time use the word neonatal acne, but usually we should not be using neonatal acne for this lesion. I will tell you why. This is commonly seen around 3 weeks of age. There is some correlation with the malassezia purpura, and it resolves spontaneously without any scarring, but it may take a few months. It looks like acne, but if you see the pathology, there is no involvement of a sebaceous gland. So this word neonatal acne we should not be using for this type of lesion. You can just clean this one with the soap and water, and you ask parents to avoid exogenous oils and lotions. Otherwise, it may block the sweat gland. Sometimes if parents keep coming and if it is very extensive, you can consider 1% hydrocortisone cream or 2% ketoconazole cream. Usually it takes few months to disappear. And if it is still there, then you can ask dermatology opinion. Now let's see some of the transient papules, vesicles, and blister. There are three types. One is the sucking blisters. You can see sucking blisters and also on the finger. And oral inclusion cyst on the gum surface. It is called a bone nodule here, if you can see. And Epstein pearls on the hard palate. And also in midline, especially around the scrotum, we can see these lesions here. That is called median raphe cyst. These are all transient. It will all disappear. Now, let's see few pigmentary anomalies, which is related to melanin. I have selected mainly the Mongolian spot, which is commonly we come across. The correct name is congenital dermal melanocytosis. So, which is usually seen around the sacrum or in the gluteal region, and also around the shoulder joint. It is usually bluish gray to greenish blue in color. And it rarely seen in the head and face. Usually it disappears in the first or second year of life. Just remember, 3% will be there even in adult life. Majority will disappear. And this is because of delayed disappearance of dermal melanocytes. So one important thing is in India, we don't see many child abuse cases. But in abroad, it is a good practice, even in India also, to document Mongolian spots in the baby book or in your note. In the future, if there is any bruise, then when there is allegation of child abuse, this documentation will help. That will also reduce the confusion. And there are other two transient lesions. One is hyperpigmentation. You can see linear hyperpigmentation here, which will also disappear in few weeks. And this is hypopigmentation. This is more commonly seen in dark complexion parents. I am sure all of you might have come across parents saying first couple of weeks the baby looked fair, especially on the face and especially on the face. Then after a couple of weeks, baby becomes the normal color baby attains. And they think it is maybe because of the moisturizers or oil. But that is not the case. Some of them may be just a transient hyperpigmentation. Baby may look fair. Let's see some vasomotor instability. Mainly three lesions we see. One is cutis murmurata, this one, all this reticulate pattern, which is mainly related to the cold. And when you warm the baby, it will usually disappear. And acrocyanosis. And Harlequin color change. You can see there is a fine demarcation, which is depending on the position we can change. Now I will deal with the birthmarks, which is the most common lesion. One is the vascular birthmark. That is vascular tumors and vascular malformations. I want everybody to get the difference what is vascular tumor and what is vascular malformation, and pigmentary birthmarks and cutaneous hematoma. So we have an international society for the study of vascular anomalies. They have divided vascular malformations into 5 categories. But let's see what is the main difference between hemangioma and vascular malformation. Hemangioma comes under vascular tumor. That is the most common vascular tumor, which is characterized by growth phase and involution phase. Vascular malformation, there is no growth phase and involution phase, which also grows as with the baby, and most of the times they do not regress. Let's see the hemangioma. This we come across. In the initial stage, it may look like this, just one erythema and some telangiectasia. It may be the beginning of the big hemangioma. Then after a few months or a few weeks, it may get bigger. This is the superficial hemangioma. This is called a strawberry hemangioma. If it is deep, it may look like this, just a bluish tinge and some raised lesion here. That is the cavernous hemangioma. So infantile hemangioma is the most common tumor, which has got growth phase and involution phase. Most of them are benign and self-limiting. Sometimes if it is big, it may get ulcerated or it may cause a disfigurement and it may compromise the vital functions, especially if it is on the face, near eyes. What are the bad predictors? If it is large in size, if it is on the face and the segmental morphology, then it may not respond to the treatment. Majority of the hemangiomas not evident at birth. It will appear after a few days to months. As all of you know, nowadays we use propranolol as the first choice. This is the American Academy of Pediatrics guideline. I know it's a big slide. I will not go into all the details. We normally start 0.5 to 0.5 mg per kg per day in 2 divided doses, and slowly we increase. Maximum we go up to 2 mg per kg per day in 2 divided doses. Some babies you may have to admit and treat. Most of the babies, if there are no risk factors, you can treat on OPD basis. Only thing to remember is the propranolol should be given soon after the feed, because it is a beta blocker. It may cause hypoglycemia. And whenever you start the medicine, you can keep the baby for 2 hours in the OPD. Or whenever you change the dose, you have to keep at least 2 hours in the OPD and observe. No need to admit each and every day for the treatment. And it's a good practice to ask pediatric dermatology before you make the decision to treat with the propranolol. We have another one which we also see very day-to-day practice, that is called Salmon patch or nevus simplex. It is a capillary vascular malformation. This is more common on the occipital area or in the forehead. You can see this reddish. Most of them will disappear. Very rarely it will persist. And you know this is a port wine stain that is called nevus flammeus. You should rule out Sturge-Weber syndrome in this. And there are some pigmentary birthmarks. One is mole. This is the mole, and cephalae spot, which is associated with neurofibromatosis, and hypopigmented patch here, that is called nevus depigmentus. Let's see few birth injuries, what we commonly come across. So most common is the caput succedaneum, which is a collection of fluid in the subcutaneous tissue, as you know, which is a boggy swelling, which fits on palpation and which crosses the suture line. Next one is the cephalometoma, which is a subperiosteal in plane, so it does not cross the suture line. You can see the 2 cephalometoma here, and that will predispose for jaundice. You can see this baby is also a little bit yellow, and most of the times this cephalometoma will disappear. You no need to do anything. But sometimes you may see, especially if it is a big one, it may get calcified, and parents will tell this head shape is also abnormal. So that calcified cephalometoma may persist for few months. You can see in this X-ray. This is the calcified part of the cephalometoma. And when there is a traumatic history of delivery, you may see sometimes subgaleal hemorrhage. It becomes an emergency. Sometimes the baby may present in shock. You may have to resuscitate with blood. And also it predisposes to jaundice. This is subgaleal. Almost 20 to 30% of the blood volume can be accumulated here. It's a very big space actually, subgaleal space. And other thing is subcutaneous fat necrosis. I have seen many similar conditions, especially after the HIE, therapeutic cooling. When cooling everything happens, when they go home, after a few days, they come with the erythematous, very indurated flakes or very warm to touch also, like this. Especially it is common on the back. And our concern is whether it is a cellulitis or it is just a subcutaneous fat necrosis. Sometimes it is very difficult to differentiate. So most of the times we may do some septic workup and give the oral antibiotics. It is usually a self-limiting condition, which usually takes 6 to 8 weeks to disappear. But we need some long-term follow-up. But because we know this lesion can have a hypercalcemia in the first few months. So we have to measure the ionized calcium, at least at the time of diagnosis, again after 1 month, 1.5 months, and 2 months. Just to be aware of this condition. Sometimes there is no history, any significant history. Baby may still present. But I don't know, in India, I have not seen many cases. And we have a transient neonatal pustular melanosis. It usually starts with the pustules. This is different from erythema toxicum. Here you can't see any erythematous base. In erythema toxicum, there is a redness. Here there is no redness. After a few days, it becomes a pigment like this. All this pigmentation you can see. Sometimes in a baby, you can see all the pustules and pigmentation in one go. Good news is no treatment is required. It will disappear. Now let's see other common problem that is called cradle cap. Everybody is seeing in the daily practice. This is the mild version. This is the maybe severe version. And I just want you to remember this seborrheic dermatitis can present like a diaper dermatitis, like this. So normally, what is the treatment? All these greasy scales you can remove. For that, you can apply the oil and leave it overnight. And in the morning, you can wash it off with the shampoo, with the soft toothbrush or comb, that fine tooth comb. But they should avoid the oil on the scalp. Only to remove this greasy, scaly stuff, they can use the oil or shampoo. Then they have to clean it. But they should not be putting oil regularly. That you should advise. And diaper dermatitis. Somebody was telling that there was no diaper dermatitis before the invention of diaper. Now everybody is wearing diapers, so we are seeing diaper dermatitis almost most of the babies, if they are not changing the diapers frequently. Now, main differentiating point is it spares the labia, this one folds, thigh folds, because there is no collection of water, moisture there, so it's spared. You can see the rest of the part, it is erythematous. It is mainly, the diaper dermatitis is a very umbrella term. Ideally, we should be using the word contact irritant dermatitis or chemical dermatitis. Diaper dermatitis is just an umbrella term. Better to avoid these terms. It is mainly when the urine and the stool comes into contact with the skin because of the ammonia, it gets irritated. So this is the candida diaper dermatitis. You can see all the satellite lesions. You can treat with antifungal for a week. And sometimes you see aplasia cutis congenita. Now I have finished all the common skin lesions. So now I will take you through what are the common assessment tools we can use in our NICU. This is one of the common assessment tools people use. That is called neonatal skin condition score. There are 3 components. One is for dryness, one is for erythema, one is for breakdown. And each one is given 3 scores. One is the perfect score. So perfect score is total score will be 3, worst will be 9. Then in Cloud9 we use this Braden scale. I know this it's not projected properly, but mainly we concentrate. This is mainly to prevent pressure injuries. We mainly concentrate on the moisture, activity, and sensation. There are a few points here, and other places people use a Glamorgan scale. In Australia and all, they use mainly Glamorgan scale for the pressure injury prevention. So there are three categories depending on the score. 10 plus is at risk, 15 plus is high risk. When it crosses 20 plus, it's a very high risk. So that time we have to be very careful. And this is another one we use frequently in the NICU. I'm sure all the NIC units should be using this. This is called VIP score, Visual Infusion Phlebitis score, to prevent all the extravasation phlebitis, and we have to change the cannula. If you follow this score very carefully, we can avoid many complications. If you see carefully this score, when it reaches score 2, then we have to resite the cannula. There are so many options here. Okay, now let's see regarding the bath. This is one of the most controversial because every unit follows their own protocol. But when to give the first bath, that is the question. In any baby, if they are in NICU, we give the bath only when they achieved full cardiovascular and thermoregulatory stability. Then only we can give the bath. There is no urgency. So even just a plain water is more than enough to give the first bath. And in a term baby and all, we can consider a pH neutral cleanser if you want. And any bath should be less than 5 minutes of duration. And you should follow your infection control procedures. And please don't remove the vernix caseosa, because which acts as a natural moisturizer. You should keep it on. Don't remove it. When to give the subsequent bath, daily bath. This is mainly for the term baby. We have to use the warm water, at least 38 to 40 degree. And the water depth should be until the shoulder. And you can add a cup of just a bath oil and or pH neutral cleanser. And external environment should be warm, heated actually. And make sure you dry the folds. Most of the times we tend to forget to dry the folds. Otherwise, it may cause injury, all this infection or injuries. And disinfect the bathtub before and after the use. But regarding the preterm, when to give the bath? Less than 32 weeks, they say just use the warm water and just with the cotton wool. That is more than enough. And no cleansing products are required. And avoid rubbing the skin. Just use the warm water and don't rub it. Just be gentle on the skin. If a baby is more than 32 weeks, then you can consider using a pH neutral cleansers. And no need to give bath every day. At least once in 2 to 3 days, it is more than enough. Only if skin is dry or flaking or cracking, then you can consider using the emollient. Coming to umbilical cord care. So everybody is aware, we have to keep the cord dry as much as possible. And when cord is intact, better not to use the alcohol wipes. It is mentioned if you use alcohol wipes this stage, then that will delay the cord form basically. And you can use a cleanser. You can clean with water and a pH neutral cleanser if it is soiled with the urine or stool. And keep the cord clamp in situ until it gets separated. Wherever possible, umbilical stump should be kept exposed to air or loosely covered with the clean cloth to avoid irritation and promote healing. So let us see a few points about coconut oil, because in India, most of the units use coconut oil, easily available, and which has got many advantages also. If possible, better to use virgin coconut oil. It is costly, but easily available, because it is rich in MCT. So it has got very good moisturizing effect. We all know it improves skin integrity. And you can start coconut oil even soon after 24 hours if a baby is stable. And we can continue the oil until discharge or 37 weeks corrected. This I have taken from Perth group. They, in their protocol, they have done this study where they used less than 25 weeks, one sachet 4 times a day, first week. And more than 25 weeks, if a baby is in the incubator, they used one sachet twice daily. And out of incubator, one sachet once daily. So now here also we can get coconut oil in a separate sachet. Better to avoid the whole bottle. Better to go for that 5 ml sachet is coming. Even if it is not virgin coconut oil, but normally also it is easily available. That will help reducing the infection. And this coconut oil better to avoid applying on the face and scalp and wherever there are vascular access. And no need to rub very vigorously, just to be gentle. And gentle strokes more than enough. And this whole application should take place around 2 minutes. No need to spend more time, just gentle application. Now coming to the adhesives, which we commonly use. This is one of the common sources for skin injury. What are the common good adhesive tape we can use? One we all know, Tegaderm, and this silly tape. This is very baby friendly. Then Deoderm, and here we have Exoderm. Please make use of these things. And there are some best practice guidelines for prevention. It is said we should use always the smallest amount of tape as possible. And it should be transparent as much as possible. And better to use hydrocolloids under the tape. And when we do so many heel pricks, and please don't put any band-aid or anything, just use cotton. And whenever you are peeling the adhesive tape, when you are removing, it should be parallel to the skin instead of straight up. So this just to be aware. And hold the skin surface next to the adhesive when you are removing the adhesive tape. You can use Vaseline or warmed saline wipes while removing. That will help in the removal. And you have to stretch the transparent film to release. And also you have to do it very gently. You should have patience. Otherwise, as I told you in the beginning, it will peel off the epidermis. And always don't forget the pain control. So we use so many respiratory monitors and respiratory gadgets. This is one of the tape we can use to prevent CPAP injury. So this is the one. It's a Deoderm, which you can use it on the skin where all the CPAP probes are coming in contact. This will reduce the nasal injuries. This is the Deoderm. And this is the CPAP prongs. So in the past, I used to see so many CPAP injuries. So baby could have spent 3 months, 4 months in the NICU unit. Baby has done fantastically well. But when you see these babies in the OPD, you will feel so sorry for the baby. But nowadays, because of our understanding and better nursing care, very rarely we see. Even I don't remember when I saw these things. In the real clinical practice, we should not be seeing these injuries. If you take care of all the measures, how to prevent pressure injuries, then no baby will end up in this position. These are the nasal injuries you can see. And this is the columnar erosion because of the prongs. You can see here. These are very difficult to treat. Most of the time it will persist. And we use so many gadgets in the NICU. Everything comes with the risk. So this is the SpO2 monitor that if you don't remove every 2 to 4 hours, then it may cause erythema and pressure injuries, especially when this part is edematous or if blood supply is poor, then it may cause pressure injuries. So when you put tight ID band, if you don't give importance, then it may cause the pressure injuries. So we have to be very careful. It should not be too tight or too light also. And I'm sure still we use a Dynaplast to fix the ET tube. That is okay. But always remember on the skin, first you apply either Tegaderm or Deoderm. On the top, you can use the Dynaplast. If you don't put any tape, if you directly use the Dynaplast, just imagine how much skin peeling will happen when you remove it. So I request everyone, please use some kind of protection there. Usually Tegaderm or Deoderm really works very well. Then you can use the Dynaplast. This is the extravasation of IV fluid. Sometimes we come across. Some people irrigate with saline, or some use hyaluronidase, some use even, especially when inotropic support is extravasated, like adrenaline, dopamine, they use phentermine. There is controversies. Some don't believe in that. Some believe in the extravasate, that flushing, irrigation, basically. I have done a few, but in Bangalore, I have not done so far. I have not come across any bad extravasation. I don't know what others follow in the unit. Do they still use irrigation? Let's see what are the best practice guidelines for prevention of pressure injuries. First of all, we have to monitor very regularly. And we have to use protective padding. And we have to keep changing the position. And we have to rotate CPAP mask and prongs. Or if you are comfortable with the mask, that is also fine. Main thing is we have to monitor. And always use skin protection whenever you use CPAP. And change the probe regularly. And sometimes I have seen people leave the BP cuff on. So that should not be done. Once BP is measured, you should always remove the cuff and re-measure again. Otherwise, it will cause all the pressure injuries. And monitor all tape frequently. So let's see a few common antiseptic agent we use in the unit. One, we use chlorhexidine gluconate. See, best disinfectant is chlorhexidine aqueous solution. I don't know that is available here in India. I have not seen. Most of the time we have chlorhexidine 2.5% or 0.5% in 70% alcohol. We all know chlorhexidine reduces skin colonization, even reduces the contaminated blood culture, which is effective against gram-positive and gram-negative bacteria. No evidence it reduces bloodstream infection. FDA's warning is we have to be very cautious when we use below 2 months. So sometimes it can cause, if you use higher concentration, it may cause chemical burns, or even it is detected in the serum also. Because the skin is so thin, it can be absorbed very easily. And povidone iodine also we use, that is popularly called betadine, which also reduces the skin colonization, which also reduces contaminated blood cultures. But there is no evidence it reduces the bloodstream infections. Whenever we use iodine, it may cause a thyroid dysfunction. We have to measure the thyroid function, especially in the preterm. What is the best practice guideline? Whenever you use any discipline, you have to allow at least 30 seconds or 1 minute. You have to wait patiently. Then whatever excess use or pooling has happened, you have to remove then and there. Otherwise, if you wait for the procedure to finish, that much time skin would have already reacted and erythema might have caused. So just avoid pooling of disinfectant. And currently there is no evidence to recommend any one particular product. So you just follow your local policy. for the skin disinfectant. Thank you for your patient listening. And
Thank
one more thing, I have to thank my IT person Lingesh and Dr. Syed for sharing and helping me to prepare some beautiful slides. And Dr. Samipa Mukherjee, she is our pediatric dermatologist. She has shared some good articles. Thank you.
Today she'll be moderating the session. Thank you, Dr. Prasanna. So it was a wonderful presentation, and most of the common things you have covered. And I request all the participants to stay till the end. We're going to have a lovely discussion moderated by Dr. Samipa Mukherjee, pediatric dermatologist. Just now you mentioned her name. She will be moderating the session, and we welcome her for the session. Now I request Dr. Ravi to start the session. Dr. Ravi Kiran is the most busiest and a wonderful human being, extremely good neonatologist, and he is chief consultant neonatologist pediatrician at Sakar World Hospital. Dr. Ravi, over to you.
Hi, Dr. Prashant. Can you, have I started to share the screen?
Your voice,
Am I audible?
you're audible. Voice, lot of echo is there.
Am I audible?
Better.
Echo is, I think, is from your side there. Hello. ಆ ಕಡೆಯಿಂದ echo ಇದ್ದಾಗಿದೆ. Hello.
Better now?
Fine. Okay. Am I sharing my screen?
Yeah. We can see your presentation. It's better now. I think the disturbance is reduced. Over to you.
Okay. Hi. Good evening, everybody. All the esteemed neonatologists and my respected teachers and my friends. So first of all, I would thank NNF Karnataka for providing this platform, and in particular Dr. Dinakar and Dr. Prashant for keeping this going like it is going. Thank you very much. And my topic for today is neonatal orthopedic issues. It is important from a few perspectives. One is it's more important for long-term physical quality of life of any neonate. And though mortality-wise, yeah, some issues are important. In NICU, we are a little boggled by the mortality deriving issues, but then neonatal orthopedics is a silent physical quality obstructor. And apart from that, this is a tremendous anxiety for the parents. To alleviate their anxiety, we need to have definite protocols, have definite pathways as to how we handle this. And this is a dynamic subject which is undergoing a lot of change, lot of changes in terms of the recommendations, protocols, as the evidence is accumulating, and as the rigors of testings are done based on evidence-based medicine. So the recommendations are changing every day, and to that extent, one of the important issues for today would be developmental dysplasia of hip kind of issues. So I have made an effort to try and summarize a little of these. Okay, so it's a wide topic. So the orthopedic part of the neonatology, neonatal orthopedics is mainly categorized into it can be divided into congenital issues, birth trauma related issues, and the infection related issues. The congenital issues again can be grouped into lower limb, spine, and upper limb. For a neonatologist, of interest would mainly be lower limb, and in that also we would be more focused on hip, the DDH, and foot for the CTEV, vertical talus, or other foot abnormalities. Sometimes knee for its congenital hyperextension. As far as birth trauma is concerned, skeletal injuries, brachial plexus injuries, and spine injuries are important. Skeletal injuries would be fractures of upper limb mainly, clavicle, humerus, and and epiphyseal fractures. Lower limb bones are quite strong as to not get fractured during routine delivery related issues. And infection would be mainly osteoarticular infections of neonates. I would be focusing mainly on DDH and osteoarticular infections, and to a small extent on a few other issues. Also, another important note is these are all highly prone, these issues, orthopedic issues are prone for litigations throughout the, across all neonatologist circles. Now coming to developmental dysplasia of hip, this is a spectrum of disorder. Earlier used to be thought of as dislocation or no dislocation, and subluxation or no subluxation, and sometimes categorized as mild, moderate, severe, or teratogenic or reducible, with a lot of confusion about nomenclature. And later on, with understanding of the pathogenesis or the pathology, it's now clear that it's not one particular disease, but it's a spectrum of disease related to development of the hip, which is related to femoral head and the acetabular architecture. How the femoral head and acetabulum are interlinked to each other in its growth. I'm not going to elaborate on that aspect, but then the proper positioning of the femoral head into the acetabulum is of paramount importance in the development of the hip. Wherever there is any discrepancy in that, we can expect a dysplasia of the hip. So there are some terminological clarifications happening. So it's now aptly called as developmental dysplasia of hip rather than any other confusing terminologies. Even in the examinations, there are a few confusing terminologies like click and a clunk. So all of us by this time know that clunk is more important and click has not much of value. A clunk means an audible and a well-felt feel of the femoral head slipping back into the acetabulum when you do either a Barlow's maneuver or an Ortolani's maneuver. Not as if this much of confusion was not enough. Sometimes what happens when we examine, we feel that the head is moving in and around, but then it's not like a stable hip. We feel some amount of instability. So that is specifically called as instability, and it's been compared to a tennis ball rolling in a cereal bowl. Coming to the further terminology, limited hip abduction is a very important terminology for definition purposes. What it means is limited hip abduction is not a vague thing, it's a very specific thing wherein the hip, when abducted, when a 90-degree flexed hip is abducted, the abduction is not more than 60 degrees on the affected side. And along with that, limited hip abduction also means that there is the difference between the contralateral side is lesser than if the contralateral side has an abduction of 70 or 80 and this one has minus 20 of that, then that's also termed as limited hip abduction. So hip abduction is limited if it is less than 60 or minus 20, then what is in the opposite side. And then equivocal would be if it is more than 60, but still the difference between the opposite side is less than 20. And equivocal is also the terminology used for other non-specific signs like Gallagher's signs positive, instability, or we have some amount of subluxation. All these come under equivocal. Coming to the epidemiology of DDH, it's not so very uncommon to say so. It's in 1 in 1,000 of neonates have some degree of dislocated hip. But if we stretch our definition to a little unstable, clinically unstable hip, then it comes to 10 per 1,000. 10 per 1,000 of the hips are clinically unstable. And if we further extend our definition to pick all the hips which are even imaging-wise unstable, some degree of unsure findings in ultrasound, then it comes to a whopping 15%, so which is a huge number. And how much of it is significant, how much of it is not significant is always a matter of debate, and that is a ongoing analysis, ongoing ongoing balancing which is happening as to where we stop, where we screen. And coming further, it's most common in females, firstborn females. Most of them, 80% are firstborn females and firstborn. And it's more in left side. 60% of it is left side, which goes with the left occipital anterior position, which is the commonest position for a breech delivery, frank breech delivery. And the otherwise it's also 20% is in right side and other 20% is bilateral. Coming to the other risk factors. So if one sibling is affected, we have 6% rate of 6% risk of getting affected. If one parent is affected, it's 12%. And if one sibling and a parent are affected, the risk almost is 1/3. That is 36%, more than 1/3. 36% is the risk for getting a DDH. In the breech, even a breech delivery is a risk factor, but more important is a frank breech, which is in the 3rd trimester. Rather than if there are other kinds of breech, frank breech sustaining in the 3rd trimester is of utmost importance. But even a breech delivery itself is a risk factor. Other risk factors, as we know, oligohydramnios and swaddling culture. When swaddling is done, if it is done in an extended swaddling is done, it presses at the greater trochanterus and it pushes the hip to come outside. So that is a risk factor. And other findings which can be associated with DDH would be torticollis or any other lower limb deformities. Now coming back to the most important question, to screen or not to screen. So to screen or not to screen, there are a lot of pros and cons. The evidence is, as far as the recommendation goes, it's grade C, meaning it's either derived by consensus of a group of experts, or it's disease-oriented evidence, meaning to say we don't want to miss the disease, so we better do more disease-oriented evidence, or usual practice opinion, or a case series. Now, what are the pros for screening? One is it is silent in the first year, and if we detect it, it is treatable. Second is, if you find an unstable hip by 2 to 3 years in your clinic and you have by chance attended the delivery, then we know how guilty we feel or how litigation prone we are. So this is a poor prognosis, and here the balance greatly tilts towards screening. Over the next few slides, we'll understand what all to screen, whether ultrasound is important, all that. But ultimately, for an individual clinician or an individual neonatologist, not to miss an unstable hip, not to miss a DDH is very important. So if unstable at 2 to 3 years, then it's a poor prognosis. This is a vital thing which tilts the balance towards screening. And the most common cause of hip arthritis, any female who's less than 40 years of age. And it's also the most, 5 to 10% of the THRs are accounted for by DDH. Now coming to cons, why we should not, why do people think about whether to screen or not, whether to include it in the public health program or not, in abroad where it's a public health program driven. In our country also, what are the points against routine screening? One argument is there's little evidence and it's not uniform. There is little evidence and it's not uniform, but then it's not favoring to miss any of the DDHs. And the second argument is many mild forms need no treatment. Yes, you screen, you identify it as mild, and if it doesn't require treatment, don't treat it. But then it's important still to screen, is what I feel, or what generally people across here feel. And treatment, if an over-aggressive treatment can cause avascular necrosis, but that depends on how the treatment is done, whether it's done in overextension, over-abduction, or if it is done in the safe zone, which is important. That's usually an orthopedician's call, but then it's important that avascular necrosis is an important cause of problem in very mild DDHs if it is aggressively treated. And ultrasound cannot differentiate between disease versus developmental variation. Okay, of course, we'll leave it to the those who derive the consensus to decide on that. But then for us, it's important to screen. Then about the clinical screening, how we do screening, it's based on what age we meet the kid. Once we attempt the delivery before discharge, we better do one screening with Ortolani's sign. Ortolani's sign, as we all know, it is flex. This is a picture of Ortolani and Barlow's maneuver. The first one is Barlow's, and the second one is Ortolani's. In Ortolani's, that is the second one, we give a traction with a pressure at the greater trochanter to slip the femoral head, which is already displaced, back into acetabulum. So this is, we are not provoking it outside, but we are just pulling it back. That means to say it's already displaced. So this is a very important sign. So we are not, though we haven't done anything to push it out, it's already outside. So ortholysis is the single most important maneuver to check for a DDH or to screen for a DDH. So coming back to the original screen, ortholysis sign is the most sensitive examination finding in patients in babies lesser than 3 months of age. That is reducing already dislocated hip. If they are after 3 months, ortholysis has less value because it will almost fade out. We will not be able to slip it back. So slipping, in that case, limitation of the hip adduction is the most sensitive examination finding when the baby is more than 3 months. Limitation of hip abduction, as we discussed earlier, it is less than 60-degree abduction or lesser than 20 degree than what the opposite side can do. Once we are done with these two tests and we categorize as some problem with the hip or unstable hip, then ultrasound is very important. Ultrasound is the next, it doesn't come into clinical screening, but then it's a part of screening. Ultrasound in coronal and transverse plane with or without stress is done, and it is classified by a well-defined classifying system called graph system, which is based on some angles. Now we know Ortolani and Barlow's. Barlow's is the first two pictures in the first column. So here the hip is there in its place. It's not dislocated. So we push it back if there's any slight instability so that it goes back, and then we pull it back. So there's an argument against doing this because of the possibility of creating an unstable hip or we adding to the trouble of what is already there. So Barlow's is still a matter of question whether to do or not. But whatever it is, we have learned this as a continuum, and we probably continue to do this as a continuum. We try to push it and get it back. So, but be in our pressure limits, we don't exceed too much. Next, other signs of hip dislocation for DDH are all quite important as a collective to guide our thought process, but it's not individually diagnostic. Example would be an extra crease, which we can see here. And another test called Klesic test has been taught often. Maybe we would have learned with different names based on the eponyms given, but then what it means is when you put a point at the greater trochanter and the anterior superior spine, if these 2 points join and the line when extended crosses the umbilicus, then it's okay. Above crosses the umbilicus is okay. But if it goes too much below the umbilicus, that means to say greater trochanter is higher up and there is an amount of posterior dislocation of the hip there, or amount of subluxation or dislocation. So this line should pass through the umbilicus or above, but it should not go below the umbilicus. Now coming to the dislocation, coming to the process of screening itself, whenever there are risk factors, what are the risk factors for just a minute. The risk factors would be a girl child, a breech, or a family history, as we had discussed. Any risk factor itself is significant enough to not neglect, though the physical examination finds anything or not. So physical examination of all newborns after birth is a must. So we have to do a physical examination of all newborns, irrespective of risk factors are there or not there. If there are no risk factors and the physical examination comes out as normal, okay, we just go for the routine follow-up. And if it is abnormal, we refer them to orthopedician at any point in time, be it in the risk side or in the no risk side. If it's abnormal, they'll go to the orthopedician, and if it is normal, they go home if there are no risk factors. But even if it is normal in those with the risk factor, they don't go home, but they are called for an ultrasound at 4 to 6 weeks of age to look for normal to mild dysplasia. And if there are any dysplastic signs, again they will be screened. They'll be sent to the orthopedician. And if it is not, then routine screening at regular intervals has to continue for them. Clinical screening at regular intervals has to continue. So the risk factor itself is an important thing, so that we continue to monitor them for well beyond the neonatal period. Coming to those who are equivocal, subluxation or abnormal examination, orthopedician is sent to orthopedician. But if it is equivocal, then a repeat examination is done at 2 weeks. And there, if it is again normal, they go back. Otherwise, subluxation, they go back. But again, if it's unstable, you call back. So in all probability, we have to be more careful in sending them back. So orthopedician has to be kept in loop by this time. Again, there is grading. One of the two is good enough. Like for a girl, follow periodically, and for a breech with a girl, imaging is strongly recommended. For a breech with a boy or a girl without a breech, then imaging is optional. Ultrasound is the definitive imaging for a kid who is less than 6 months, because the ossification centers are not very clear. After 6 months, radiography in consultation with pediatric orthopedic surgeon is important, and graph classification for ultrasound defining is important. Coming to the, once we decide that it's to be treated, then it's not orthopedician job. Public harness is to be done, and one thing we have to keep in mind is that it has to be attempted only on a fully reducible hip. Complications should be avascular necrosis if it is done on a forced hip abduction, and femoral nerve palsy can happen because of hyperflexion if it is done. The concept of triple diaper for preventing is outdated, or rather not to be practiced strongly, because that will give the parents a false reassurance and it may not help in any other way. They have found studies with and without triple diapers, and there was no difference in babies who were on triple diapers for the future outcome. So that was about developmental dysplasia of hip. Now I would be talking about another important factor, which another important part of orthopedics for neonatal. It's neonatal osteomyelitis and septic arthritis, or we can together call it as osteoarthritis or bone and joint infections. Here there's a lot of difference between Western scenario and Indian scenario in terms of the statistics. So most of the times we follow Western literature initially until we know the differences. So here in India, incidence is close to 1 in 1,500, which is quite high. Whereas the same in UK and US, the numbers are very minimal, like 1 in 5,000, 1 in 15,000 in US. And they coexist. So in 76% of the osteomyelitis, you find a arthritis also, septic arthritis also. So whether they are the same entity or they are a different entity, after understanding the vascularity, we will come to the conclusion almost that they are a same entity in different spectrums. Preterms are more affected than terms, and male to female ratio, for unknown reasons, it's skewed to 1.7 males, 1.7:1. And then it is different than in children, and it is not the same as childhood osteomyelitis. Neonatal osteomyelitis is different than childhood osteomyelitis, and it's definitely not the same as in the developed world. We have more infections than what they have, so it's definitely not the same. So what are the risk factors? Risk factors depends on the route of spread. So osteoarthritis in neonates is mostly hematogenic. So all the risks of a bacterial infection, that is bacteremia, are also the risk factors for this. So any of our NICU procedures which are invasive, be it catheterizations, in specific umbilical catheterizations and groin catheterizations are at risk. So any invasive procedure could be a risk. So asepsis and need-based catheterizations are very important. Other infections like UTI, skin infections, and cut downs can also be contributing to the infection. And in a preterm, when we are doing a heel prick, that itself can be a risk factor, but this is not hematogenous. This is for a direct acquired infection. Similarly, cephalhematoma is another direct risk factor. Secondarily infected cephalhematoma can be a risk factor for osteomyelitis of the skull. It can also be transplacentally acquired or ascending through when there's a PR wound. Coming to the pathogenesis of osteoarticular infection is mostly related to its vascularity. So I'll first go to the osteoarticular vasculature, then we'll go to the pathogenicity. Once a nutrient artery enters the diaphysis, it ascends to the joint above. At the joint above, it takes a sudden angular bend. At this angular bend, the blood flow becomes very sluggish, and here the arteriole changes into a sinusoid, venous sinusoid. So at this bend, there's a sluggish circulation, sluggish enough to allow the bacteria to lodge there, and the baby already the neonate is low on its the immune capability of a neonate is low to mount a antibacterial resistance. So this is an easy bed for the infection to set in, and the sinusoids which are starting here lack phagocytes. So this further leads to unbridled multiplication of the bacteria. So the metaphyses where the vessels bend are the commonest site of infection, or are the lodging of the bacteria. And this is also very important because from here on, the blood vessels migrate across or cross the physis, cross the growth plate to enter the joint also, to enter the epiphysis, cross the physis to enter the epiphysis. These are actually the nourishing vessels which are very important for the growth of the epiphysis and the growth of the baby. Unfortunately, this is the only drawback, so it can lead to spread of the infection across the physis into the epiphysis. And the metaphysis itself in in newborns can be intra-articular. So the metaphysis can be intra-articular, which could lead to metaphyseal infection going into the joint. So when the metaphysis is so closely linked to the joint and metaphysis are not two different places. They are continuity of the same. So osteoarticular infection and arthritis, the joint infection and the osteomyelitis are both same. Ultimately, do we need to consider all the previous studies of osteomyelitis and arthritis as the same or as different? That's something we need to think about. And then the next thing here is, this is the same depiction of the vessels entering into the epiphysis. So now coming back to the previous slide, metaphysis of long bones of the leg are the most important foci of infection, more than 50% of them. Here at abrupt terms, there's no phagocytes. I just told you this. It's sinusoid, sorry for septic arthritis. These vessels go to the joint space in the first 1 month of life. Meaning epiphysis in the first 1 month of life. And this leads to bony destruction, and also the metaphysis is intra-articular here. The same in a pictorial depicted form, nutrient artery, metaphysis, transphaseal vessels, and the epiphysis. This leads to, ultimately, the infection here can damage the epiphysis and the epiphysis growth plate, which is the important reason of long-term morbidities. So pathogenesis further, what all it can do, an intra-articular pressure here leads to dislocation of some joints like shoulder joint or hip joint, and the infection can spread across the shaft under the periosteum like a telescope around the bone, and the thin periosteum can rupture out easily, allowing for decompression there but entering into the soft tissues of the skin. This is important because instead of going into the bone, it decompresses into soft tissue. So the chronic osteomyelitis is lesser because of this reason, and also because of the rich vascularity, the sequestrum which is formed because of the bony destruction is easily resolved, and bone destruction is also lesser. And involucrum, which is a formation of the new bone, is also very rapid in neonates. This leads to rapid remodeling, and also this rich vascularity helps in a good antibiotic penetration, antibiotic entry into the area, and so it's quite treatable if it is picked up early. So here, this calls for an urgent diagnosis and immediate management so that we don't allow for long-term morbidity. Coming to the microbiology, what are the organisms more common? So on the left side, I have mentioned about the textbook mentioned organisms, but Indian scenario based on one study in Chennai is written on the right side. So Staph aureus, in particular, MRSA, if it's a prior colonized organism, group B streptococci, and coagulase negative staphylococci. These are the common organisms, and they have found that gram-negative was only 5% in their study. And matrix binding molecules, which are there in staphylococci, are the important binding regions, and they protect them. They create a local slime which prevents them from getting affected by the host immunity. Other causes sometimes have been documented: atypical, TB, fungal. These are rare. And in Indian scenario, by a study from Ramchandra Hospital in Chennai, they have documented more of gram-negative organisms, mainly Klebsiella. 72% were gram-negative, of which 36% was Klebsiella. Other 36% were made up from by E. coli and Staphylococcus. So Indian scenario, we have more of gram-negative organisms also because of the iatrogenic issues. So what are the challenges? Challenges are that physical signs are frequently minimal. Laboratory findings, they have found out also there are two spectrums of the disease. One spectrum is a preterm in the hospital who is sick. Who sick, and the other spectrum is a kid who comes after 2 weeks of discharge. So generally, sicker babies are very sick, and non-sick babies are very difficult to identify unless we have a keen suspicion about that. Laboratory findings may be normal. Initial X-ray is often not useful because of the cartilaginous tissues, but on a close look, we can definitely make out some contour abnormalities in the bone, the periosteal reactions, the periosteal thickenings, and the surrounding soft tissue swellings. So in spite of the, these are the challenges, and in spite of the best management, the prognosis is poor because of the growth plate getting damaged, and permanent disability can be quite high. The range has been from 6 to 50% depending on where it was, how it was handled. In one Indian study, the diagnostic criteria had been well mentioned. The diagnosis of septic arthritis confirmatory would be by culturing an organism in the joint aspirate. Blood culture may or may not be positive because it's a confined space. And if blood culture is not possible, then a surrogate would be Morris criteria. Morris criteria is useful. It has been divided into major and minor criteria. 2 major criteria and 5 minor criteria would be good enough, would be required for diagnosis. The major criteria are you aspirate joint, pus from the joint, a high ESR, and radiographic changes which are suggestive of osteoarthritis, like osteolytic lesions or joint effusions or synovial thickenings. Synovial thickenings is later, but joint effusions and surrounding soft tissue endowments. Minor findings would be the findings of typical findings of any inflammation and sepsis. Inflammation would be fever, calor, dolor. That is, baby has a fever, baby has a pain which is worsened by gentle passive motion, and there is swelling, and also these are the general features of inflammation around the local area. Apart from that, any features of sepsis, lethargy, malaise, irritability, these are all minor features individually. Though lethargy, malaise, and irritability both have put it as a single line, one of them is also taken as a minor criteria. And a satisfactory response to the antibiotic therapy, that is test of treatment, is also one of the minor criteria. And ultrasound showing joint collection or joint effusions. The findings on radiology would be dependent on X-ray or ultrasound. X-ray and ultrasound are the most commonly used techniques. Though X-ray is more important for specificity, ultrasound is very important for sensitivity. And it's very vital that we do ultrasound on any suspected joint, because ultrasound is available, people are trained in ultrasounds, and if not, so that we don't miss infections. The X-ray findings should be related to the bone, maybe osteolysis, bone deficiency, periosteal opposition, periosteal new bone, eccentricity of the head, demineralizations. And ultrasound findings should be more of soft tissue, joint effusion, synovitis, periosteal abscess, eccentricity of the femoral head. Coming to MRI findings, yes, these are some of the MRI findings, and the pathological technician bone scan would also be confirmatory, but then technician bone scan is a controversial issue, whether to do or not. It's not clear about that. Chronicity is rare because of the reasons what we discussed, and then the complications are chronic osteomyelitis, permanent joint disabilities, disturbances in growth plate, secondary damage to cartilaginous growth plate, and decreased range of movements and pathological fractures. Treatment, of course, is antibiotics and surgical. Antibiotics, there are a lot of different protocols, but then what's important is a good coverage of staphylococcal, gram-positive and staphylococcus. That's either oxacillin or cloxacillin. And if you're suspecting an MRSA, vancomycin, and an amino glycoside for suspected gram-negative gentamicin or tobramycin. This was a study of a recent study. It's a retrospective study in a French hospital discharge database for over the last 11 years compilation of data. They had 71 babies, of which average age was around 25 days with an interquartal range of 17 to 43 days. The organisms were typically what was defined for the Western literature, like group B Streptococcus, Staph aureus, and E. coli was less than that. And apart from most of them, nine of them were nosocomials. They had pyelonephritis, skin and soft tissue infections. Antibiotics have been, as we had discussed, but one important finding in this was IV plus oral antibiotic median required was 45 days, but this was earlier going up to 66 days in 2004. Now, because of the routine antibiotic surveillance and other QI indices in place, the antibiotic duration has come down from 66 days to 42 days in 2014. Now, I will just touch upon a few other important aspects. The foot is important. Here, foot can be, what's important for us is the talotibial joint, which is the ankle joint, wherein we have a plantar and dorsiflexion. And the next important is the talocalcaneal joint, which is the subtalar joint, where the inversion and eversion happens. And the associated ligament should be important. So here, pes planus are flat foot, we know. In flat foot, we know that it's not a cause of concern. If a flat foot is rigid, that is, we are not able to dorsiflex, then it's a problem. And it's more important to know this from the point of view of not missing more severe issues which can present as flat foot or which we mistake as flat foot. One of them would be calcaneovalgus foot. In calcaneovalgus, there will be a valgus deformity. On an external appearance, yeah, we can miss that. We know that it's not a CTEV, but we also know that it's not looking like a flat foot. So here, calcaneovalgus also, it's not so, nothing needs to be done actually, but we have to identify that so that we know the exact how it's going to recover. But more problem would be the congenital vertical talus. In congenital vertical talus, on external appearance, it looks like a flat foot, but this is something which is not treatable by routine techniques, or which is to be managed aggressively by an orthopedician. So when a flat foot is there, make sure that it's not a congenital vertical talus and refer to an orthopedician if need be. So, and a few notes about the brachial plexus injury. Brachial plexus injury is quite common. It happens in 1 in 1,000, mostly in macrosomic primipara mothers. And shoulder dystocia and aftercoming head are the important causes because of the overextension of the neck. And no obvious expression can be there in 50% of them. These are more common in macrosomic and lateral neck traction. Arms are extended over the head in a breech presentation. Approximately 45% are associated with shoulder dystocia. Clinical features could be paralysis of the entire arm or the upper arm, with or without the paralysis of the forearm or hand. So if it's only the upper arm related, the prognosis is quite good. Treatment is mainly supportive for the first few months. That is passive stretching and physiotherapy, massage, exercise, and Faraday stimulation. And Erb's palsy, C5-6, we know this. And how do we recognize? There's either the portal stiff hand or motoreflex is absent on the affected side. Sensory impairment would be there if we patiently examine. And the power in the forearm and the hand grasp will be lesser at that time. So this is a typical portal stiff hand. So what is to be done is a passive range of movement exercise for 1 week, and should be started at least by 1 week, but not later than 3 weeks. And then shoulder abduction and elevation is limited to 90 degrees for the first 3 weeks time. And then serial evaluation with the physical therapist is important. But if the baby does not recover flexion of the elbow joint by 3 months, it's not a good prognostic finding. So better we refer to the orthopedician if we find it's more severe. Fine. Prashant?
Yeah.
Yeah, hi. So, yeah, I think I'm at the end of my
Dr. Ravi.
presentation.
Yeah. So the session is open for discussion. I request Dr. Sameepa.
Yes, sir.
Yeah.
Good evening.
Yeah, she's a pediatric dermatologist. I request you to say a few words and your perspective, what a neonatologist needs to know, pediatric dermatology, important things for a clinical practice.
All right, sir. So, neonatologists and pediatricians, I will probably be concentrating only for the term infants, and we will be probably looking at just the first year of life. It's very good to see Prasanna sir. I have not visited hospital for so long, and I'm getting to see him. So I'm really thankful, and I'm thankful to you, Prashant sir, for allowing me to be here and to be speaking. We will start with the very basics. So bathing, I think sir has enlisted everything. Now, below 2 years of age, if we are looking at anything which is a cleansing agent, we would be looking at a non-soap cleanser, which is pH balanced, or a Syndex soap. So the choice is dependent on the weather conditions and on the skin condition of the child. So if we are going to be staying in a place like Bangalore, which has dry climatic conditions, a cleansing lotion, which is non-foaming, is preferable. But if you're going to be in an area like Chennai or Mangalore or Mumbai, which is humid, then a Syndex soap is what can be used. Now, we never ask patients to dilute anything. We always tell, put it on your hand, foam it if you want, and you apply it to the full face and body and wash it off. Temperature of the water is always lukewarm, and we wipe the baby. We don't rub the baby dry. That's the first thing. Second thing is oil massage. Prasanna sir has already told about virgin coconut oil and plain coconut oil. The other reason for choosing, apart from whatever sir has said, is the percentage of oleic acid in virgin coconut oil is very less. It is just about 7%. So that is the reason it doesn't cause any irritation, or it doesn't have any potential of causing contact sensitization. That's one reason why we prefer virgin coconut oil. If we want an alternative to it, liquid paraffin or light liquid paraffin, which is not perfumed, would be another option which can be used. If you are going to ask olive oil, badam oil, or any of these mustard oils, etc., it is to be avoided for various reasons, basically because of the components that it has and also because of the density of the oils. Third thing, coming to the moisturizers, again, very, very important, because every parent would want, which one to apply. I will not be taking brand names here, but I will just let you know about the ingredients which is involved. So when the medical reps come, you can always ask about the specific ingredients which the product contains. Now, my favorite, all-time favorite to be used is a combination of white soft paraffin and light liquid paraffin, because both of these products are absolutely inert, and when used externally, they do not have any chance of causing any sort of a reaction or a side effect. Now, these need not be the best versions to be used in a setup where it is humid again, because patients who sweat, they will not be very comfortable with products which have white soft paraffin and light liquid paraffin. So for those patients, you could look at moisturizers which contain oatmeals, which has a very good water holding and moisture holding capacity. Or you could look at lotion formulations as well with white soft paraffin and light liquid paraffin. Now here, if you are confused, there is ingredients which is different. So ingredients are white soft paraffin, light liquid paraffin, oatmeal and ceramides. These are the ones which are things which you want in your moisturizers. What you don't want in your moisturizer is fragrance and sulfates. Okay. Now, the debate is about parabens, which is the third ingredient which comes in as a preservative. Now, please remember that all parabens are not bad. Even our dermatological products contain parabens, and certain concentration of the parabens are allowed. Also, their carcinogenicity, if your patients are very anxious, you should be able to tell them that the carcinogenicity has been proven in higher concentrations, that too in the Caucasian skin, not in our skin of color. So I would not be worried about the paraben content of a product as much if it is within the recommended allowances. Coming to the formulation choice, if places are dry and cold, we would choose a cream or an ointment version. But if places are humid and coastal zones, I would prefer a lotion choice. So these are the few things which we land up using on a routine basis in practice. Second, I think fourth point is about powders. Now, powders, we do not really recommend the usage of powders in babies below 2 years of age, not because of anything, because what happens is, the reason why we don't allow is because of the inhalational granulomas that have been documented. So it causes more problems in the lung than on the skin. So that is the reason we would prefer not to use a powder below 2 years of age. Last cream, which is very commonly used again, is the diaper rash cream. So we always see that there is a diaper rash cream along the prescription. Now that is something which I would say does no harm, but if there is no diaper rash and you want to use something as a preventive measure, you could use plain petroleum jelly as a preventive measure. The reason being, the logic to this is, see, any diaper rash is formed because of the breach in the integrity of the skin and the skin getting damaged. So if I need to actually protect my skin from any sort of contamination because of the urine or because of the stool passage or because of the wet wipes that are being increasingly used nowadays, I would want to coat it with petroleum jelly so that all all of these chemicals, if they come in contact with my skin, they don't really stay on the skin, they just, you know, sort of move out. So for prevention, I think petroleum jelly repeated application with every diaper change is good enough. We do not really require to use a diaper rash cream per se. And final part about the diaper rash cream is all the ones which are commercially available, except for a few. Again, I cannot take the brand names, but what you need to know is zinc oxide from about 12 to 17%. If it is present in the diaper rash cream, it will work as a fantastic barrier. Avoid diaper rash creams which has fragrance or which has things like, you know, added extra ingredients, aloe vera, etc., etc. It's of no use for us. So, you know, zinc oxide 17% good enough for us. 12 to 17% is good enough as a diaper rash cream. So this is about the basic skincare routine. Now, one point only I would like to add on to Prasanna sir's presentation, because he has beautifully compiled the presentation for us. But one point is about the diaper dermatitis. So this is one of my favorite topics, but this is also an important topic because patients come to us a lot later. I think they present to the neonatologist way earlier. So what happens here is diaper dermatitis is a broad term. Diaper dermatitis is any skin rash which involves our diaper area. It is not necessarily because of the diaper. So diaper dermatitis could be fungal, it could be because of contact allergy, it could be because of an irritant contact dermatitis, it could be jackets dermatitis. Diaper dermatitis, what we need to know is not because of diaper. It is because of coming in contact with certain allergens or irritants or a superadded bacterial or a superadded fungal infection. So the treatment needs to be streamlined based on that. One tip, when in doubt, do not use a combination of steroid and antifungals. We are seeing increasing antifungal resistance in pediatric age group. If you are in doubt, use plain tap water compresses, plain barrier repair creams, and plain antifungal. You could use clotrimazole, you could use metronidazole. The minute we put a steroid onto it, whether if it is irritant dermatitis, it will fantastically respond and go off. But if it is a fungal by chance, the minute you stop the steroid, it's going to just come back, you know, in a very, very bad way. So, you know, the parents will be scared, you'll be anxious, we'll be anxious. So that's the reason. Avoid combination creams. If in doubt, use an antifungal for your diaper dermatitis. So that is one point which I wanted to say. So Prashant sir, I think the second common thing which we missed out was malaria, sweat rash or prickly heat. It's a very, very simple problem, but it generally creates a lot of concern in the patients or the parents because of the way it presents. So the time find red rashes all across the body, that gives rise to a very angry look and parents are very anxious. Most of us treat it very effectively, but I think what's important over here, one tiny tip which we use is tap water compresses. That is something which is fantastic. You just ask the patient to soak handkerchief in plain water, tap water, room temperature, soak it, squeeze it, keep that wet handkerchief on the affected area for 2 to 3 minutes. That will help in taking off the salt deposits. It will help in cooling down the skin, and you can use your calamine lotion after that, and it is going to respond very beautifully. So that's one more thing which I would want the pediatricians to know. And lastly, I think wound care management. Sir, as pediatricians, pediatric dermatologists, neonatologists, a lot of us have encountered where patients have come with the child having fallen down or hurt, and what they have done is they have applied Dettol or Savlon as a disinfectant straight away. Now, these are highly concentrated. This can cause burns. It can slough up the skin completely. So that leads to sequelae which we don't want. So what I generally request my patients to do is we underutilize this product actually. It's potassium permanganate crystal or sachet. I would request them to keep it at home. They can make dilute potassium permanganate soaps, and that can be used as a detergent or a desiccant as well as a disinfectant for cleaning the wounded areas. So these are few things which I think is important for all of us to know as pediatricians, as neonatologists, and as pediatric dermatologists, because these concerns are asked by the parents to any one of us. So, yeah, so if there are any specific queries, I'll be more than happy to answer.
There is one question which has come from Facebook Messenger.
Hi, sir.
What we should do for mosquito bite reaction? Either Dr. Prasanna or you, any of you can answer.
Okay, perfect, sir. I would request Prasanna sir to take this up and I will top it up with my opinion.
Mosquito, but first we have to do something for the mosquito. That is most important. Prevention is better. Now, if it is just a few bites, it may cause itching. That time, most of the times, baby will scratch for a few days, then everything will be fine. Sometimes that may get infected. Then it may lead to cellulitis. That is sometimes we see. Soon after the bite, there will be histamine release, so some itching will be there. I normally suggest some creams which soothes. That will help. If it is that much local, this thing is enough. Soothing cream, any soothing cream, and trim the nails basically. We don't want any infected mosquito bite.
So, Dr. Sameepa, would you like to add up?
One tiny thing over here. Now, if the mosquito bite is an isolated episode, you could treat it exactly the way Prasanna sir has told, and it will work fantastically well. What we'll end up seeing is papular urticaria or insect bite hypersensitivity reaction. Now, that is something where you would require your dermatologist assistance. The reason because here the condition becomes repetitive. So it is not just one episode of bites, it is multiple times the child is ending up with severe skin allergies. When we have actually gone back and traced the history in these patients, we have seen the atopic history in these patients is very strongly positive. So not just treating the insect bite reaction is important, but also treating the underlying atopy is important. Second thing that I generally tell for my patients with insect bite hypersensitivity reaction is that this is a process which is going to come down with time. So you will have multiple episodes, but the severity of the episodes is going to keep on reducing. Now, needless to say over here that because atopy component is there, the child will have severe pruritus and there will be secondary excoriations. So these are places where we can end up using a combination of a very mild strength steroid along with an antibiotic in a tapering schedule over a maximum of 10 to 15 days. So that will help in cutting the cycle of the insect bite hypersensitivity reaction and relieving the child early.
Thank you. They have asked one more question. How to differentiate between dry skin, which we see over the cheek, versus atopy?
Sir, I can't hear you.
Dry skin versus early atopy. How to differentiate?
Okay, all right, perfect. So, all right, dry skin is very easy. Dry skin may be sporadic in nature in the form of site of involvement or the time when it is involving your skin. Time meaning which time of the year. So if I don't have atopy, but if I have dry skin, maybe it is concentrated only on certain areas of the body, maybe only my cheeks. And it becomes apparent only during either season change or during winter season. So it's a seasonal thing and it is there. Now, if I have a history of any sort of repeated cold, allergic rhinitis, any sort of asthma, dust allergy, any kind of persistent dry skin, eczemas in the family at any point of time, or allergic conjunctivitis, any of this, if it is present either in the child or in the family members, the history of atopy becomes positive. So that is when you will suspect that atopy may be there. And of course, there will be other features. So you will have an extra Denny Morgan fold. You will have palmar hyperlinearity. The dryness will not be confined to only one area. It's more of a diffuse dryness, and it is more exaggerated in areas like the shin of the legs, etc. So those will be there.
The use of steroids, because the moment we see dry skin and if it is not getting better with moisturizers, we use hydrocortisone. How safe it is, and what are the safe steroids to use, the percentage, the mild, moderate to potent steroids, which one to use, and what is the point where we need to refer to the dermatologist?
Okay. Sir, very tough question because it differs from patient to patient. However, if there is no eczematization, so if there is no rash formation, avoid a steroid usage. Okay? If you see a rash which is light red in color, it is not oozing, it's a dry dermatosis, restrict up to the level of hydrocortisone and desonide, which are considered very low strength and low strength steroids. Any steroids, always taper and stop. So it's never morning and night 7 days and stop. It's always ideal morning and night 5 days, only at night 5 days and then stop. Okay. Any dermatosis which is not responding to your conventional treatment beyond 7 to 10 days, seek a help from your dermatologist colleague. When we are talking about the higher strengths of steroid, we talk of clobetasol, which is very commonly used by pediatricians, fluticasone, not so commonly mometasone. So coming to fluticasone and clobetasol, clobetasol up to 15 days continuous is okay. Beyond that, stop. Okay. Fluticasone not beyond 10 days of continuous usage. If your dermatosis has to respond, it will respond. Most of the time, sir, in 90% of the patients, the dermatosis responds. It is the rebound that is the problem. So if you are facing a rebound, do not go back to the steroids. You might seek the help from your dermatologist colleague because we have non-steroidal anti-inflammatory agents which can help in the form of topical calcium urine inhibitors, which can help in these dermatoses. And of course, we need to know the indication for it. So for example, if I see, very commonly we'll end up seeing malaria with eczematization in the neck area, I will not go ahead and straight away give a fluticasone. I will give tap water compresses, a basic moisturizer, and maybe desonide cream just for about 10 days and stop, and it will respond.
Thank you. There is one more question. Either you and Dr. Prasanna combined you can answer, or separately you can answer. This is about disinfection.
This is about?
Skin disinfection while inserting the central lines or IB lines. Am I audible?
Yes, sir.
Yeah. So should they use povidone or chlorhexidine for skin preparation before they insert IB cannulas or the central lines? Which one would be preferred one for the patient?
So can I answer, Samyupa?
Yes, sir. Please go ahead.
I mean, we commonly use chlorhexidine, but ideally in preterms, I mean, I have seen a lot of chemical burns in UK. Then when they did study, finally they told 0.1 to 0.5% chlorhexidine in aqueous solution is a good one. But there we used to get it. Before we used to use initially 2%. That is what we get here, 2.5 with the isopropyl alcohol. That causes sometimes chemical burn. But most of the time, if you are careful, if you allow maybe 30 seconds to 1 minute and you wash it with just a sterile water or a normal saline, then chances of chemical burn is very, very minimal. And another mistake we commonly do is we don't see the back. We are concentrating only on the site of insertion. Sometimes you never know, it may go at the back and it will cause chemical dermatitis there. So always check it, especially soon after the application and even after the completion of the procedure. There is nothing left at the back. Now, povidone in preterms, because of the risk of absorption and hypothyroidism, we don't use much, but there is a, I mean, studies have not shown one is superior to, some studies have proven chlorhexidine is slightly better. But there is no consensus which one tops the list. That is my understanding.
Yeah. Is it the same recommendation?
So yes, I would agree with it. Yes, sir.
Is it, they've asked one more, is it the same recommendation for preparing umbilical cord for infecting UVC and UAC? It's the same recommendation for peripheral lens and central lens as well. It's a common recommendation.
Yes, you can use same disinfectant for the peripheral IV cannula also, no problem.
To maintain good skin integrity, what should be the percentage of humidification needs to be done in incubator for a premature baby first 1 week? Or,
I was told that 75 to 80% first week. Then you slowly reduce 5% up to 50% in the second week. Maximum we give it for only 2 weeks. So first week is around 75 to 80%.
Yeah, I mean, if anybody has questions regarding the neonatal skin issues, you can raise the hands, you can unmute, and we can take up the questions. So meanwhile, if the time they take to raise the hands, few questions for Dr. Ravi. Dr. Ravi, is my voice clear?
Yeah.
Yes,
Prasanna.
the question is, for how long the swaddling, what they do with babies? I mean, it's about the swaddling versus the developmental disorders of the baby.
See, swaddling, it's echoing somewhere.
I think
Swaddling in particular, swaddling when the leg is extended is the only thing that is contraindicated. When you're swaddling, only thing you have to make sure that the hip and the knees are flexed and then swaddle when the baby is being swaddled. So continued swaddling with the lower limb extended at the hip and the knee would lead to push of the greater trochanter out of the acetabulum. So make sure that when the swaddling is done, the hip is flexed and the knee is flexed as well, and over that you swaddle again.
so. If there is a milder form of CTEV, do we need to start the treatment? How early we need to start the treatment?
CTEV.
CTEV, I mean, whatever form, mild, moderate, or whatever severe.
The CTEV, if it's again teratogenic, yeah, of course you have to refer to the orthopedician. If it's a milder form, then various degrees of mild could be mild adduction only, or it could be a combination of adduction with inversion with complete abnormality also. In that case, it's definitely suggestible to start early. You have to correct all three forms of the deformity: plantar flexion, adduction, and inversion.
Okay.
So adduction alone, maybe we can leave alone, but then maneuvering to counter the adduction first and then the inversion, then the plantar flexion has to be started right from the beginning, and it is important that the mother be taught to do it about 3 to 4 times daily before and recheck after about a month's time. And if it is still not responding, definitely we have to send the orthopedician for a casting.
Okay, and what is the management for newborn hyperextension of the knee?
Hyperextension of the knee, most of the times it is self-resolving, but a casting has to be done. So hyperextension happens because of the femoral condyles going overboard the tibial condyles, and the tibial condyles being a tibia at an angle with the femur at the popliteal joint. This has to be repositioned, and then casting has to be done for up to 6 weeks sometimes for it to correct. But most of the times it resolves with simple casting. Many times, even without casting, when you re-examine the baby in about 15 days time, you will find that it's reduced quite a bit. But casting definitely helps in getting it back to the normal position.
Okay. What is vertical talus?
Congenital vertical talus is when I had, one second, can I share my screen?
Yeah, sure.
Just a minute.
Hello.
Yeah, just
Hello.
can you hear me?
Yes. Please go ahead. Yeah.
My screen is seeing.
Yeah. Seen it.
See, in congenital vertical talus, the talus which has to actually be like a stone which is like a pyramid will be vertical with the articular surface of the tibia going back. The body of the talus, here the tibial articular surface of talus, when it is vertical, will go back, leading to mild plantar flexion. Sorry, mild dorsiflexion, not plantar flexion. But this is a deformity which has to be corrected. I would rather once there's a plane, the main thing is to differentiate this from a flat foot. If a flat foot is not flexible and if it is rigid, then congenital vertical talus has to be thought of. And how do you say it's rigid or flexible? You cannot plantar flex the baby's foot for more than 20 degrees in a pes planus. In a flat foot, if you cannot plantar flex the foot for more than 20 degrees, then you suspect congenital vertical talus and refer it to an orthopedician.
Thank you. Dr. Sunil Jain.
Yeah, sir. Which antifungal to be used in diaper dermatitis case? And second is about umbilical cord care. We used to apply split. That is simple split over the umbilicus. Should it be left, right, or we should continue with this split?
Hello?
Yes, sir.
Because it is mentioned, if cord is intact, that time better to avoid spirit, even though it causes a dryness. But studies have shown it will cause more days to heal, and umbilical will fall a little bit more later. We don't use spirit swab or alcohol swab wipes when cord is intact. Once the cord has come off, that time you can use alcohol wipes to clean.
Thank you, sir. And what about the antifungal cream to be applied in cases of diaper dermatitis?
Sir, if you are looking at plain antifungal creams, you could choose the basic molecules, clotrimazole or miconazole. Both of them are very clearly available, easily available everywhere, without any steroid combination into them. Plain antifungals.
Clotrimazole or
Miconazole.
Not for if it is a fungal diaper dermatitis, then you are using antifungal.
Okay.
If it is a chemical, you are not using antifungal.
Okay, thank you.
So we should stop using the word diaper dermatitis. We should add something in the front, and you have to treat the cause.
There is one more person who has raised his hand. I don't know the name.
Myself, Dr. Naresh Prasad.
Can you please introduce yourself? And
Myself, Dr. Naresh Prasad from Dhanbad. Sir, I wanted to know how much beneficial or harmful it is to use kajal, which is often applied over the eye, over the forehead, or over the neck in many places of India. And do we recommend any medicated stop for the neonatal bath in the newborn? Regarding the extravasation injury, I want to tell that we should elevate the bath within 24 or 48 hours. The edema subside, but these children should be protected against this staphylococcal infection.
okay, so your first question is kajal, use of kajal.
It is often practiced all over the country, applied over the eyelids, over the forehead and the neck. Is it harmful or it is beneficial? And any recommendation of medicated soap?
Okay, I got the first part of the question. It is about the application of kajal in neonates, I think.
Yes.
Correct? Okay. So kajal, we do not recommend it, sir. No, where any part of the body we say a no. But generally the parents resist this, and more than parents, grandparents resist this. And to conceive that, we allow to apply kajal on the palm or on the sole where the skin is made thicker. But we do not recommend the usage of it anywhere else, neither on the forehead or around the eyes area. Whether medicated kajal, non-medicated kajal, homemade kajal, it does not matter. We do not recommend the usage of it. The second part of the question I didn't get, sir. Something about soap.
Any medicated soap we do recommend in our neonatal practice?
No, we do not recommend the routine usage of a medicated soap. No, definitely no. So if we are talking about below 2 years children, I already told that if you are staying in a humid climate, you could use a Syndet, which is a moisturizing pH balanced. Most of them are without fragrance. So you can ask for this term Syndet, S-Y-N-D-E-T, to the reps who come and meet you. So they will give you the names of your Syndet soaps. And if you're staying in a dry climatic zone like Bangalore, you could use the non-soap or the non-foaming cleansing lotions for wash. They do a good job. Medicated soap, no.
Is there any role of zinc in? Is there any role of zinc in neonatal dermatological practice?
Sir, is there any role of
Zinc.
zinc? Okay. So not in neonatal dermatological practice per se, sir, but in pediatric dermatology, we use zinc as an immune modulator in multiple disorders. So we use it in vitiligo, we use it as an adjuvant in alopecia areata, we use it in the treatment of extensive warts and molluscum, and basically as an immune booster. Also, zinc has been shown to play a role in skin maturity or skin integrity repairing. So if there is a wound which is non-healing for some reason, and if you want to give a zinc as a supplement, you could use it.
Thank you, madam.
Thank you. So we have one more person who has raised hands, Dr. Paramji.
Hello, am I audible?
Yes.
Dr. Sameepa, thank you for enlightening talk of yours. I am from New Delhi.
Yes, sir.
Am I audible?
Yes, sir.
Okay, so the conditions over here in summers are temperatures between the highest temperatures are around 45 and minimum is about 30. In the winters, it goes down to about 15 and the minimum goes down to 4. So,
Okay.
could you tell me the bathing routine for a normal term baby and a preterm baby without any risk factors? When should we start giving them a bath? Okay, that is, see, Dr. Prasanna had already told us, but when should we start? Normally, as soon as the babies get to start, let us say the baby is a normal baby, the baby gets home on the 3rd day. So the baby, in a preterm baby, in a term baby, the normal bathing procedure and which soap to be used in such conditions?
Right, sir. I will deal with the term baby first, and then we'll go to the preterm. So if we are talking about the term baby, we are, and if you are dealing with summers, so you can start bathing as soon as the child reaches a stability, whether it is cardiovascular, respiratory, or a thermal stability. Earliest we can give bath is within 4 to 6 hours. Okay. Now,
Right.
the frequency of giving bath, we could give it on a daily basis, but an alternate day bathing is generally a more preferred option. But if you are talking of temperature reaching as high as 45, even a daily bathing will not do harm, sir, to the baby. The duration of the bath should not be more than 5 to 7 minutes. The temperature of the bath, water should be lukewarm, or it should be basically the room temperature water. Last thing about using any soaps or cleansers for the term babies, sir, cleansing lotions is what I generally recommend. If it is below 6 months, definitely cleansing lotion. Between 6 months to 2 years, you have the choice of either a cleansing lotion, which is non-foaming, or you can use a Syndet soap. These are the recommendations for bathing during summers for a term baby. Coming to the winter recommendations, Only the frequencies of bathing is going to change, sir. Not the duration, the temperature of the water to be maintained at unit. And the type of bathing, instead of doing the dip bathing, or instead of giving the bucket and the mug method of pouring, you could use sponging method. The frequency of baths during winters could go down to only 3 times a week. And you need not use a soap on a daily basis or a cleanser on a daily basis for these babies. Okay?
My question to you is in the winter month, when the temperature is about 15 degrees maximum,
Okay.
and minimum is about 5 degrees,
Yes.
and during the day hours, 15 to 20 is the temperature, and is a term baby, about 4, and in the second month of age, about 4 kilos. Can't we give a bath daily to that kid?
Sir, you could give a bath, but if you're going to ask me a general recommendation, I'm just saying that giving a bath every alternate day or in the very least thrice a week is not going to be harmful.
Okay, thank you.
Right? Coming to the preterm, sir, everything changes actually. Okay, preterm, I think I would request Prasanna sir to say it, because I do not deal with the preterm so much, because they are mostly maintained in the NICUs, etc. So Prasanna sir will take that question on, sir.
Okay.
So preterm baby, if we have discharged the baby, if they are still less than 2 kg, then no need to give the bath daily. So we normally suggest giving bath to preterm babies when they reach at least 2 kg. That time you can consider giving daily bath in summer season. But in winter, you can still give alternate bath. There is no need to give daily bath. It is not necessary. What is more important is how to take care of the skin. It's not the bath. Bath time, okay, 5 to 7 minutes, 5 to 10 minutes. Then how to apply the emollients. Those are the things. How many times? We have to take care of the moisturizing effect of the emollients. So bath, there is not much controversy. If because we have to make sure baby does not go hypothermic. That is more important. That is when baby is discharged home. But in the unit, we give normally the sponge bath. Only when baby is very stable, then they take baby out of the incubator. They give very quick bath in the, like a tub. We have a stainless steel tub, and they finish within 3 to 5 minutes. And before that, we have to check the temperature. We have to make sure baby is ready for the bath. Then soon after the bath, we have to again check the temperature. That is within the NIC.
Right. Thank you so much.
Yeah, thank you. And they've asked about commercially available potassium permanganate, trade name they've asked.
See, I do not write a trade name. When I'm writing on the prescription, I write it as potassium permanganate crystals, bar powder, bar sachet. And if you go to any of the medical stores, mostly it is available, at least in Bangalore, sir, in our Cloud9, it's available in these tiny packaging, which is like a yellow and a blue carton. It comes written as potassium permanganate crystal or sachet.
Okay. Yeah, umbilical granuloma they've asked to Dr. Prasanna.
Very nice. It's very, very easy to treat. Okay, there is a beautiful paper. So traditionally, I think copper sulfate is what has been used, but there is a very beautiful paper very recently published. I think 2019. It was published by the dermatologist. So what they did was, you take a not a toothpick. You can probably take a earbud. You can just wet the earbud. Dip it in plain salt, the table salt that you have. Roll the earbud in it so that it's laden in salt. Apply it to the umbilical granuloma and create an anaerobic environment by just taking that area. If you leave it under occlusion for 24 hours, the granuloma desiccates. And I have used this for our babies. It works fantastically.
So 24 hours, we need to issue it.
Yeah, just tape it. You could use a micropore tape, or if you want, you can use the Tegadown dressing also. Just tape it and close the entire umbilical zone. So there shouldn't be air entry into it, and leave it off like that for the next 24 hours. And the granuloma desiccates. It's beautiful. It's very rewarding actually.
Yeah, so we have to take an earbud. And
Earbud? Take salt, sir.
The rock salt or the powder salt?
Plain powder salt. Plain powder white salt. You can dip the earbud in normal saline and take the plain salt with it. Just apply it to the entire umbilical granuloma. Tape it off in a cross pattern and leave it for 24 hours. It desiccates.
Okay, okay. Thank you. Dr. Dinakar, sir?
Prashanta.
Yes, sir. Yes, sir. Would you like to...
Beautiful talks. Beautiful talks.
We can't see you. Dinakar, I can't see you.
No problem, no problem. Okay, I'm listening to you. Prasanna, really nice topic. You have made it very simple. Even postgraduates understood what you told.
Thank you.
Consultant understood what you are going to tell next. Really nice topic. Number one. Ravi Kiran talk was also very nice.
Yes, sir.
And everything he covered, including birth injuries, all those things. Ravi, very good talk. Okay, moderation was excellent. Today it is a crown for all the talks. So as usual, she is the queen. So crown should be there on the thing. Okay, very good. So very nice topics, and even many people, almost 252 members have logged in. It was a very good talk. Thank you very much, Prashant, and very nice effort. Thank you both the speakers and moderator for your effort. Prashant, over to you.
Thank you, Tariq. Thank you very much. I'm flooded with all the feedback. They have told me to convey the feedback to all the three speakers and the moderator. Thank you, Dr. Ravi. Thank you, Dr. Prasanna. Thank you, Dr. Muniyappa. Thank you very much. And I would like to thank all the participants who have been consistently being part of this web series. Thank you once again for showing such great urge and passion to learn and being with us for almost more than 2 hours. Thank you very much. We will see you again on tomorrow. We have a session coming up on neonatal development care. It's going to be quite interesting, and which is going to cover a lot of things related to the neonatal therapy. So we have got speakers, great speakers, who have done a lot of work in neonatal therapy. So please do join us tomorrow at the same time at 5 p.m. You all have a great weekend and a safe, and stay at home if it is not required to go out. Thank you.
Thank you.
Thank you, sir.
Thank you, Samit.
Thank you, sir. Bye-bye. See you.
Bye.
Bye. Bye.